Hello and welcome. You are listening to Transplant Talks, conversations about living donation, produced by myself, Kush Damkewala, and hosted by Rachel Davis. Transplant Talks is dedicated to raising awareness and understanding about living liver and kidney donation. Our host, Rachel Davis, brings a unique perspective to this conversation. She is both a non directed living liver donor and a medical doctor here at the University of Colorado Anschutz School of Medicine, where she practices as an associate professor and vice chair for clinical services in the Department of Psychiatry. Her clinical work and research focuses on psychiatric neuromodulation and other novel treatments for severe obsessive compulsive disorder and other treatment resistant psychiatric illnesses. Her interest in living donation stems from her own experience donating the right lobe of her liver in January of 2022, an experience that she describes as profoundly positive and life-changing. This month, in honor of Hispanic Heritage Month, we have Dr. Sixto Giusti joining us, and he's going to talk more about how our Hispanic program is changing lives every day. Over to you, Rachel.
Thanks, Kush. And thank you so much, Dr. Giusti, for joining us. I'm excited to talk about this. Can we start out by having you tell us a little bit about why we're talking about Hispanic Heritage Month on a podcast about living donation?
Of course, it's my pleasure to be here. I'm very thankful for the invite. So I think it's a great month because we are highlighting our Hispanic heritage culture in this country, and at the same time, putting an emphasis or a focus on kidney patients needing the life-saving gift from an organ transplant. So there's too many people waiting for a kidney transplant. At the same time, we don't have enough diseased organ offers to get them transplanted and save them from being on dialysis. One of the key things that we can do as a population is increase the rate of living donation. So the more living donors come forward, the more we're going to be able to chip in that needle and help more patients waiting on the deceased donor organ transplant. In the Hispanic population per se, studies from the late 2000s and early 2010 did show that by implementing a Hispanic transplant program, by providing culturally appropriate care and orienting this patient population, we saw an increase in living donation. So I think it's important to highlight that by providing culturally appropriate care, we can make a big impact in this population and increase the rate of living donation in both kidneys and in liver.
So there's a lot to unpack in there. So hopefully we can get into more detail. Can you tell me a little bit about the Hispanic Transplant Clinic? Who started it? When did it start? What is it? How did it come to be?
Of course, so it started in 2018, and the Dr. Elizabeth Pomfret, which is the head of the transplant surgery, and she's the president of the American Society of Transplant Surgeons this year. She came up with the idea where she saw the need to provide culturally appropriate care to this Hispanic community. Dr. Pomfret, along with Monica Rafals, which was the transplant nephrologist at that time, started that initiative. It started slow but steadily, and it consists of trying to have key players in the transplant team that speak Spanish or at least are culturally competent to provide appropriate care for these patients. So right now we have myself, a transplant nephrologist. We have pre and post coordinators. We have a living donor coordinator. We have social workers, pharmacists, and financial counselors, all speaking Spanish. Most of them are Hispanics and culturally competent, and they are able to provide care in the same language, and it has been very, very helpful. So it's just this mindset of trying to understand this patient population and try to tailor the appropriate therapy according to their needs. So that would be the gist of what the program will bring to the table.
Okay, thank you. And how did you become involved, and why is this work important to you?
So I was in Tulane Medical Center. I was the medical director of the kidney program there. And in 2021, Dr. Monica Grafals approached me because they needed more Hispanic providers just to try to keep up with the increasing volume. And that's how I ended up being here. The idea seemed very attractive to try to help Spanish speaking providers, something that I was missing by being from Puerto Rico and being Hispanic. So the idea was very enticing. And I love what I do, and it's super exciting. But when I came in here, I said like, "Oh, that's gonna be great," but I didn't know how impactful it was going to be in terms of me personally and the satisfaction that I'm getting out of it.
How long have you been doing this for?
Since 2 years now, for the
Okay,
last 2 years. So
okay.
I'm just still starting, I would say, and there's lots of work still to be done. So we got our clinic recognized last year for the service award in Colorado by the NKF. Trying to prepare for like the speech, I realized by speaking with my own mom that she had the same issues. So my grandparents emigrated in the 60s to New Jersey, looking for like better opportunities, and my mom was born there. And by the age of 4 or 5, she started having asthma issues. They didn't know what was it back then, but they eventually moved. My grandfather had a great job. He was like the head of one of the factories, but eventually they had to moved back to Puerto Rico because they couldn't get appropriate care. Like physicians didn't speak Spanish, were not willing to go the extra mile to provide the appropriate care, and they eventually had to move. I think like, oh wow, it makes more sense what I'm doing because I know what they are going through and my own family has experienced it. I know I have even more reasons for why I would be doing this.
So it's especially meaningful to you.
So,
Well, before we jump into living donations specifically, can you expand a little bit more on why this is important? So the health disparities that Hispanics face in our countries specifically and difficulties accessing transplant.
So yeah, so what we've known from probably 20 or 30 years more of data is that Hispanics are disproportionately have a higher rate of CKD, like a higher chronic kidney disease burden. They have a faster progression of kidney disease compared to non-Hispanic white individuals. So for example, they are 1.3 times more likely to have kidney failure compared to like a white American. Diabetes, which is the main cause of CKD, and end-stage kidney disease in the United States affects more Hispanics than other ethnicities. Currently, about 20% of Hispanics in the US have diabetes, and it's expected that at least half of them will experience diabetes along their lifetime. They have higher rates of hypertension, will be the number two cause of kidney disease. So we know that from the get-go, they have a higher propensity, or that explains why they would have a higher propensity of having kidney disease and eventually end up in kidney failure needing transplant. We know that they have a difficult or more difficult getting access to healthcare, whether it's culturally, economically. There are multiple factors that might explain that, but we know that it's harder for them just to establish care with a physician. Once they are established care with a primary care physician, we know that it's harder for them or takes longer for them to refer to a nephrologist, which is an important step in terms of prevention. If you get kidney disease early on, you can tackle diabetes, you can tackle high blood pressure, or the other modifiable factors, and we know that we can slow the progression of kidney disease. But unfortunately, that doesn't happen. Once they have been referred to a kidney doctor, we know that they take longer to be referred to a transplant evaluation. Early transplantation is the ideal scenario, and we know that the earliest that you can get referred, the quicker you can get listed and potentially avoid being on dialysis, which will take a toll on your body, will have other consequences. Once they are on the waiting list, at least before they were taking longer to be transplanted than any other ethnic groups. Data from 2015 and forward have shown that we are doing better in that aspect, and they have pretty comparable rates of transplant. But another aspect, or the other aspect, we know that they still get lower quality organs, like higher KDPI organs, more ischemic time. So there's health disparities across the board from the beginning to even at the transplant stage.
So out of all that, I now have a lot of why questions, and maybe we don't have answers, but do we know why the Hispanic population is at higher risk for diseases such as diabetes or chronic kidney disease?
So there's multiple theories, multiple hypotheses. So there's a genetic component, there's a cultural component. So obviously diabetes and all these conditions might have a genetic predisposition. In addition to that, culturally, our diet might be different from the typical Mediterranean or Dutch type diet, which would be ideal. It's rich in carbohydrates. So dietary factors play a role. On the other aspect, socioeconomic status also play a role. We know that immigrants coming in this country and Hispanics might not be able to afford the healthiest option, might not be able to afford preventive care. So there are several factors, but I would say those will be the main ones that are contributing to these disparities or the discrepancies. So we have the genetic component, we have the dietary component, the cultural component, and then the socioeconomic component as well. And keep in mind that, for example, Spanish-speaking patients have like that taboo with healthcare. They think that they might be taken advantage of, or they might not be taken appropriate care of. So there's this hesitancy to seek out care too as well.
And does
Go ahead.
that play into why it takes longer to refer for transplant, or that's another why question? Why does it take longer to refer?
It's very hard to pinpoint. I think that all of the reasons above mentioned are in play. There might be other factors, unfortunately, in terms like getting adequate insurance, or I know of some providers personally that don't think that they will do as well as the other population because they don't understand the language. So I think that's the other potential factors that might play a role in that delay, unfortunately.
Some false judgments and probably misconceptions playing in here. So you started to tell us about the Hispanic transplant clinic, and I want to ask you broadly to say more about that, but I'm curious, you used the word navigator. Can you say more about what that means? What's a navigator?
So it's just somebody that knows the system that is willing to go the extra mile to help them throughout the whole process. Our assistant, which is Breezy, is doing essentially the job for that. We also have like the social worker and the coordinator, they all come into play and act essentially as a navigator. But what the navigator does is just literally helps the patient navigate this complex system throughout the whole process. To put it in perspective, if there was any question throughout the process, she was going to be available. So it's just trying to help literally, or the simplest definition that I can think of is just trying to help patients navigate this complex system.
And otherwise, the patient might be left not knowing at all what's going on and what next steps are. And I would imagine that would be also a very scary position to be in.
Yep. Yes, ma'am. I think obviously Dr. Cervantes, who has done tremendous work throughout the spectrum, has shown too that, and in other disciplines, including oncology, the role of the navigator has been vital in
Yeah.
improve patient outcomes and patient care and satisfaction.
Well, and speaking of outcomes, how do the outcomes compare to transplant in general?
So we have internal data led by myself and Dr. Jesse Scholl that is showing that the 5 years outcomes are better. So all the Hispanic kidney transplant patients have better 5 year outcomes when compared to whites and African Americans and other populations. There's data from 2010, 2011 that shows something similar. They did 3 years outcomes, and most of the patients or the Hispanics did better, particularly the older population. In our data, throughout different strata of age and cause of end-stage kidney disease, they have better 5 year outcomes in terms of less graft failure, which is very, very rewarding. And say like, all right, we're doing something right. There's definitely a great reason why we should keep doing this and trying to move the needle and bring more culturally appropriate care to transplant these patients. Interestingly, it also showed that they tend to get lost to follow up on the long term. So we believe that there's some disparities happening at that stage in time. I don't have any clear-cut data, but anecdotally, the patients on our Hispanic clinic that are referred to the community and are not able to establish care with like a Spanish-speaking provider or a culturally appropriate provider are calling us like, hey, can I come back? I'm not getting the care I need. So one of our theories is that might be affecting or that might be contributing to why patients might be lost to follow up in terms of kidney care and might be just opting for primary care if they feel comfortable with that provider.
Sure. And when you talk about the better outcomes, is this across the Hispanic population in general, or is this within the context of patients who've received culturally appropriate care?
In Hispanics in general.
Okay.
Hispanics in general. Our own internal data from the Hispanic transplant protocol did show the same. They do as good as any other ethnicities or like English speaking patient.
Wow. So you mentioned briefly the idea of some taboos about seeking healthcare. Can you say more about that? And in general, if there are other barriers besides what you've already mentioned in moving forward with the transplant process?
So I think in lieu of the theme of the podcast, I think it's great to bring this forth. For example, a good example that I can bring is the living donation. So culturally, what I've noticed is very hard for individuals, like for parents, the Hispanic parents, to accept the gift of life, like a daughter or son donating a kidney. So that's a big taboo for them. It's like, oh, we are very paternal. I don't want to hurt my kid. I don't want to do this to my kid. So what we do, for example, I try to spend at least 15 or 20 minutes during the initial eval. Almost always all the family is there. And I try to spend some time explaining and answering questions in details or in depth about living donation. We also do at least twice a year what we call in English Big Ask or Big Give conferences, which are sponsored by the National Kidney Foundation. So these are all Spanish lectures, and we spend like an hour with patients. We invite all the families. I probably spent 30 or 40 minutes going over the slides, and then the whole hour just bouncing forth questions from patients. Once you get them going, all the slew of questions arise. And what we notice is that with thorough orientation, we have seen an increase in people coming forward in donation. The last time that we did it in March, there was a recipient, which was the mother, in this diabetic, who was reluctant to accept the daughter from just coming forward for at least 2 years. She was blood type O. She probably had another 2 or 3 years of waiting. And after that lecture, we kind of convinced her, or she felt more comfortable accepting the daughter. The daughter submitted the evaluation the next day, and they got transplanted like 2 weeks ago. And so far, they're doing great. So those are the things that tell you, like, okay, this is working. And there's data from Northwestern, from Dr. Gordon and Dr. Caicedo. They implemented the same or something similar, and they were able to build the Hispanic Living Donor Program and increase their volumes and outcomes. So,
Oh, that's amazing. I think a lot of people may not even be aware that living donation is a thing and that it's doable and relatively safe. What are some of the most common questions that people ask you when you do these conferences?
So I think I am as thorough as possible. So I give them all the spiel, and what I've noticed is that we underestimate our patients and we don't tend to give them all the full spectrum information. So I go from the basics to the more in-depth, try to cover everything. So I think the main question that is always the hardest to answer is, what are my chances of ending up in kidney failure? Which is the hardest question to answer. And it's so I am very passionate about living donation. And I wish we have a precise answer for that one, but we don't have it yet. Why? We would need thousands of patients for like 4 or 5 decades. That data is ongoing, but we don't have that precise data. There has been some models that they have tried to numerically calculate the specific risk factor for individuals. What we do know is that overall, the chances of you having end-stage kidney disease after kidney donation are usually less than 2%, close to the 1%. And you say like, wow, that's pretty low. Yes, that's pretty low. And why? Because if you're a viable living donor, is that because you're healthier than the general population? And this, with the same line of thought, we know that living donors or patients that are viable donors have lower rates of end-stage kidney disease than the general population. For the same reason, they're healthier. So that's usually the hardest question to answer. There are other common questions, at least in the Hispanics, for example. Oh, I want to get pregnant in the future. We know that there might be a slight increased risk in, for example, preeclampsia and gestational hypertension. In the general population, it's somewhere about 4 to 6%. Some studies show that percentage might increase 8 to 10%, but there are other studies that have shown no difference. So I do tell them like that there might be an increased risk of these conditions that should not preclude you from becoming pregnant. I would encourage you just to establish care with a high risk OB potentially, but other than that, all the women that have donated have been able to successfully become pregnant without major issues. So as long as you have good monitoring, that should not be a contraindication either. So that's probably like the second most common question that I get. So age, that's another question. How old can I be? Usually you have to be older than 18 and younger than 70s. There are some centers, at least before, that were accepting higher older donors in our centers. 70 is the cutoff, and it's shown that the graft don't do as well, and then obviously the donor might not do as well. But mainly it's because the graft outcomes are not great, are not ideal. Also, other questions that I would say, what are the strict contraindications? So if you're a diabetic, that's not ideal for you. If you have uncontrolled high blood pressure, donation might not be for you. We tend to accept controlled high blood pressure usually with one agent. If you're talking about two blood pressure medications, then we might say no. We know that living donors that are older than 50 and have high blood pressure have a higher risk of end-stage kidney disease. But otherwise, as long as you're younger than that and your blood pressures are lower than 140/90, it's still probably safe for you to consider donation. If you're obese with a BMI of 32, that's probably a no. Recurrent kidney stones, that's probably a no. And frequent UTIs. Those are the things that I usually tell them, like, hey, if there's anything of this, then this might not be the ideal thing for you.
Kind of a basic question that can you say or tell us a little bit about how the person can just go about life with one kidney? How is this possible? Like, do we really not need the second one, or what's the deal with that?
So if you're healthy, I mean, human body is amazing to start. And if you're healthy, what's going to happen is that the other kidney will grow or hypertrophy and try to compensate for the other lacking kidney. We expect about a 70% residual GFR. So let's say that you have 100 mLs per minute GFR after donation. We expect that you're left at least with 70 mLs per minute. And healthy individuals, let's usually lose less than 1 point of GFR or 1 ml or GFR per year. So depending your age, that's probably going to be more than enough for you for your lifetime. We know from at least 2 or 3 decent studies, long-term studies, once you're healthy, won't control high blood pressure and other issues, you will continue to hypertrophy for the remaining 5 or 6 years. So it's going to keep getting better.
Okay. And GFR is basically how well your kidneys filter toxins, right? Okay.
So it's glomerular filtration rate. It's a fancy word for how well your kidneys are doing. We tend to use, for the calculation, we tend to use a creatinine, which is a protein that we have on our muscles. We secrete in our bloodstream and you urinate it or you clear it out of your body through your kidneys. We measure it in the blood. The lower that creatinine is, the better your kidneys are working because you're filtering or excreting into your urine better. With that, along with age and other factors, we calculate a percentage of how well your kidneys are working. We have a grade from 30 to 40-year follow-up data knowing what will be your ideal GFR based on your age. And we tend to use 1 to 2 standard deviations of it. Overall, the bare minimum that a donor should have is about 80% or 80 mLs per minute of GFR. But that's if you're on the older, if you're 25 or 30, I expect that GFR is at least 120 or so, just to put it in perspective. Because we know that you're gonna live and you need to have a better GFR or a better kidney function to donate.
That makes sense. So what about worst case scenario? What if someone donates and they do end up with end stage kidney disease? Do they just end up on dialysis, or what happens then?
So unfortunately, we have had the cases of former living donors ended up in kidney failure for a myriad of reasons. I had a case 3 years ago of an older sweet lady that donated her to her twin in her 20s, and she was in her 70s, and she developed diabetes around the age of 50, didn't live the healthiest lifestyle, and then ended up in kidney failure. We have what we call not a safety net, but we try to protect former living donors, and they are given priority on the waiting list. To put it in perspective, that lady had to wait 2 weeks once listed for a transplant. So instead of having to wait years, you will be given priority if you're a former living donor across all other subtypes, including PET. So you will get priority, and ideally you will get transplanted sooner than the rest because you were a former living donor. But that's something that we try to avoid at all costs. But unfortunately, it happens.
Well, and I think you're highlighting something important is the baseline risks for chronic kidney disease won't change after donating a kidney. And so while donating a kidney may increase your risk, other risk factors are still there as well, right? So you, of course, can't guarantee that someone won't develop chronic kidney disease for various reasons. What do you see are the most significant barriers to living donation in the Latino community?
It's lack of awareness. They
Okay.
don't know what's the process. They don't understand risk versus benefits. They're not sure if what will be the economic burden of it, which usually, for example, the insurance of the recipient will cover the evaluation, the surgery, and short-term recovery. They don't know if it's something right for them, if they're going to be taken advantage of. So I think the lack of awareness and taboo in general is the main limiting factor of why we don't have more donors coming forward in the Hispanic or Latino population.
Which really emphasizes the importance of culturally appropriate care. I would imagine when there's a language gap, the trust issues would be significant when considering something that is, has potential to
harm, yeah.
harm you. Yeah. So how have you seen this play out with the Hispanic transplant clinic? How Like, do you have any anecdotes or data, or
So in terms of in general or living donation?
let's talk about living donation.
So like I mentioned, like anecdotally, I've seen a difference just by being able to orient them. I've seen a shift in how they think and how they perceive living donation. And number wise, we have seen a steady increase in living donors coming forward. So our across the country in general, across all ethnicities, about 30% of the transplants are from living donor. Our center is pretty similar to it. We did 100 living donors of the 300 last year. 80 of them were stayed here, 20 of them were shipped out. And I would say one fourth of them were from Hispanics, which was significantly more and has steadily increased to the last 4 or 5 years after that. So we've seen a positive impact in terms of number. And they do living donors in general tend to do well. Recipient for the clear-cut reasons that we can briefly touch on, and the donors they do well. They're healthy, and most of them are young, and they're able to go back to their normal life pretty soon.
Do we know if the Latino population has higher risks with living donation compared to general population, or
I would say it's similar. So because if you have diabetes, if you have predisposition for diabetes and all, we try to take into account all those risk factors. So they get the same screening, and if they have any of the same contraindications, they're going to be ruled out. In patients that have a genetic predisposition, meaning mom and dad, for example, were diabetes, those are the ones that are really stressed out to try to control those modifiable risk factors as much as possible. We know that there's the genetic component, but at the same time, there are modifiable risk factors that we talked at the beginning. If you're able to live a healthy diet, a healthy lifestyle with the appropriate diet, physical activity, you don't necessarily have to go end up being a diabetic. I mean, it's easier said than done, but I try to definitely grill down that idea of you can do this, but at the same time, it's going to be a big compromise the rest of your life taking care of you. If not, you might end up in the same predicament. And they tend to be very good so far about it and very understandable as long as you are able to talk to them in the appropriate language, try to tailor what you say to them. So I know what their diet consists of. We had a diabetes talk with a nutritionist and a medical part aspect of it. It was very interesting. We're able to tailor the typical dish, for whether it was tortillas or rice. And when we talked about it, it's like, hey, instead of eating 3 tortillas, just try to eat one. Instead of like a big spoonful of rice, just eat half of it. So I try to do the same in that aspect and try to tailor what they need based on their culture and what will their daily lives would look like.
well, it sounds like you're doing amazing work spreading awareness. What else needs to be done, or how can we continue to increase awareness?
So I think that just getting the word out there about living donation, just starting or sparking the conversation is a great starting point. There's multiple levels or aspects, like from a legislation aspect per se. There recently passed a bill trying to protect living donors. For example, I've seen before that some living donors might be denied health insurance or life insurance. So we need advocacy throughout the whole spectrum, from the minimum or from the ground, as we are doing, to up until the legislative aspect too as well. And for me, just getting the word out there is the best way to start. My usual spiel is like, obviously for the recipient, living donation should be the way to go. We know that it's better or superior because the kidney is going to last longer. We know that, for example, living donors, the half-life is like around 19 years versus a deceased donor around 12. So we know that it's going to last longer. You're going to start working quicker. You're going to have less waiting time, potentially avoid being on dialysis. You're going to have less risk of DGF or needing dialysis after transplant, less risk of rejection, quicker recovery, less surgical complications because it's like a scheduled surgery. So it should be the way to go. In an ideal world, all our transplants should be done from living donation. That's not the case, but that's what we aiming or shooting for.
Does someone have to be related to donate?
No, Colorado, there's something in the air. We have very high rates of altruistic donation. I think that as a population and coming from the South, people are healthier here, they're happier, and we have great rates of altruistic donation. With the saying that there's somebody that is healthy and is willing to do this as you did, and then just gets evaluated and donate. So you don't have to be related. You can know somebody, or even if you don't know somebody, but you are willing to do this, it's very important, and you can come forward. And again, we have great experience. I talking to Pomfret yesterday, she mentioned that we have the highest, or the big number one program of altruistic liver donors in the country, which is amazing. In kidney, we are not far behind. Um, another similar question is, you don't have to be compatible with your potential recipient. We have what we call the pair exchange, in which there are pairs or even chains of pairs in the same predicament, that they have a viable donor, they're not compatible, and we try to pair them with other donor recipients on the same predicament, and we swap kidneys, and everybody gets their donor organs. We have internal list, external, and at least two nationwide separate lists in which we can enter patients, and they can successfully get their living donor transplants.
Pretty amazing.
Yes.
There's two things I want to pull out of what you just said. And one is that if you are in need of a transplant, it's not only your relatives who can donate, but perhaps someone else in your life who might be willing. And they could donate if they're a match, or they could enter what you just described as the paired exchange. So that, I think, is one key point. And then the other key point is that you don't even have to know anybody. If you're hearing this and this sounds like an exciting, cool thing to do, you can step forward and be a non-directed or altruistic donor. And so if someone is hearing this and wants to do that, what do they do? How do they do this?
So it's just reach out to the transplant center, to their nearest transplant center. In the University of Colorado, we have a online website that you can access. You can enter your information, and you will undergo a basic screening. After that, the living donor coordinator will review it. They'll give you a call, go by some more questions, and see if you don't have any contraindication. And after the explanation, you decide to proceed, then you are invited to eventually come in to go the full workup.
And if you fill out this form, are you committing to donating, or are you allowed to back out at any point?
At any point. That's my first line. And usually, even if the potential recipient is in the room, I ask them to step out. This is something out of your own volition or free will, and at any given point in time, you can back off. Even on the day of the surgery, when you're about to put under anesthesia, if the donor doesn't want to do it, just say like, hey, I don't want to. And we will usually come up with a medical reason. I would say, we overlooked the CAT scan and she has 3 arteries and it's not safe to donate. So we'll look for medical reasons to exclude you, which that will allow to save face to the potential donor if they don't want to do it. But this is something out of their own volition. And we are very good at it because we know that it's important to protect that donor's right. We have an independent ILDA, the Independent Living Donor Advocates, which acts separately as our transplant team, and is looking out for the best interest of that donor, making sure there's no coercion, and throughout the process, the donor feels comfortable doing, and they can back off at any given point in time.
Is there any stigma about donating? Like, do people think this is a strange thing or a weird thing, or would people be embarrassed? Is that a concern people have?
Not a common concern, to be honest. Once they are at that process where I am talking to them, if there's a similar stigma or concern, they have already surpassed that by the point that I am interacting with them. So I don't think that's a big factor, at least not for me.
That makes sense.
Something interesting that I think is cool to mention, there's a bunch of altruistic donors in our state, kidney donor athletes, and their thing is that they hike the Kilimanjaro after donating a kidney, which
Wow.
I is extremely cool and interesting. That proves that you can keep doing all the things that you love. I have at least 3 or 4 marathon runners that donate, and then they're still, after a couple of weeks to months, usually probably 2 or 3 months, they're able to continue with their activities and strenuous physical activity just because they like it.
That's incredible.
Which is very interesting. Yep.
A few questions about you. So what do you find most satisfying about this work? Why do you like doing what you do?
So, I mean, in general, for the same reason that I got into medicine, is just to try to help others. I think that when I was younger, I had personally some similar instances in which close family members were pretty ill, and through the advent of medicine and good medical care, they were able to have a better life and live longer. So that usually what sparked my interest in considering medicine. From this aspect, I see it very rewarding for the same reasons that I would help anybody, whether you're from the United States or wherever. but at the same time, I feel this personal connection, and I feel like I'm taking care of my grandpa or my cousin or some relative just by identifying culturally. That gives me that extra satisfaction of being able to provide good care that otherwise they might not have. Unfortunately, we're always struggling and trying to hire more Spanish speaking providers, and there are not as many as we would like. So I feel very blessed being in a unique situation of trying to help this population that otherwise might not be able to receive that appropriate care, which is I would say like the icing on the cake per se. I would still do this. When I was very happy doing it in other centers that didn't have a big Hispanic population, but this gives me a little extra boost to keep going.
Well, it sounds like you do incredible work, which has had significant impact, and I imagine will only continue to have more impact. Are there things I haven't asked you about yet that you want to share about any aspect of your work?
Not that I can recall. I think we've covered almost all the bases.
Well, it's a pleasure talking with you. This has been fascinating, and I'm really glad we're getting this important word out there. So thank you very much for doing this interview.
It's a pleasure, and thank you both for putting this out there. I think it's, like I mentioned, it's so important just spreading the word out and try to spark that conversation about living donation. That's the vital first step, and you guys are doing it. So props to you, and please keep doing it.
Mhm.
Thank you for having me.